Good morning all. I'm Dr. NAMITHA SETHU. I'm a practicing periodontist and implantologist. I completed my post-graduation from Royal Dental College, Palakkad. I'm extremely privileged to present session 4 of Reading Club based on Misch Contemporary Implant Dentistry in connection with International Implant Summit 2026. Chapter 10, Medical Evaluation of the Dental Implant Patient. Clinical laboratory testing, international normalized ratio and prothrombin time. Because of the variability in laboratory reporting, the World Health Organization developed a more standardized system called INR. In a normal individual, INR value should be 1. The recommended therapeutic range of continuous anticoagulation is an INR between 2 and 3 for all the conditions except artificial heart valves, for which the INR should be between 2.5 and 3.5. Bone diseases. Diseases of the skeletal system and specifically the jaws often influence decisions regarding treatment in the field of oral implants. Bone and calcium metabolisms are directly related. Approximately 99% of the calcium in the body is held in bones and teeth. Calcium equilibrium is influenced by several different processes in the body, which then could directly affect the bone health. PTH has the most important influence on calcium by impacting the storage of calcium on bones. In elderly, there is increasing evidence to support that lower levels of vitamin D have the most influence on calcium levels. Osteoporosis. The most common disease of bone metabolism implant clinician will encounter is osteoporosis, which is an age-related disorder characterized by a decrease in bone mass, increased microarchitectural deterioration, and susceptibility to fractures. Dental implant implications. Surgical technique. Under-preparation of osteotomy site or use of osteotomes will result in the implant having more bone at the implant interface. Although not contraindicated, immediate stabilization of dental implants is a common concern because of decreased trabecular bone mass. Healing periods and implant surface characteristics should be selected for poorer quality bone. Bisphosphonate use. Oral or IV bisphosphonates are common medications for osteoporosis. Length of healing. In osteoporotic patients, there is decrease in cortical and trabecular bone. The repair process, that is implant healing, may be compromised. Sufficient time for healing should be adhered to with progressive prosthetic bone loading is highly recommended. Peri-implantitis. A strong correlation has been shown between periodontal disease and skeletal osteoporotic changes. Strict post-operative recall and periodontal evaluation should be adhered to. Progressive bone loading. Because of poorer bone quality, healing is compromised, necessitating progressive bone loading throughout the prosthetic rehabilitation. Poorer quality bone is progressively increased to better quality bone, which result in better bone quality at the implant interface. Implant design. Implant design should include greater width implant. Surface conditions of implant bodies should be designed to increase the bone contact and density. Bone stimulation to the healed interface will increase bone density even in advanced osteoporotic changes. Dental implant implications. Post-operative healing. Healing after trauma in patients with fibrous dysplasia is much different than for those with normal bone. The tissue is hypocellular, which leads to slow healing and an increased infection rate. These local infections may spread through the bone and result in more advanced complications. Informed consent. Because of the lack of research and studies, patients need to be well informed of possible morbidity and complications. Treatment summary. Active lesion areas are absolute contraindication. Non-lesion areas, relative contraindication. Vitamin D disorders or osteomalacia. Osteomalacia results in softer than normal bones and is directly related to calcium deficiencies. Lack of vitamin D is the most common cause of osteomalacia. Osteomyelitis. Osteomyelitis is an infection
with or without inflammation of the bone. Always the infection is caused by a bacteria or fungi entering the bone. Open wounds or recent surgery around the bone are the most common sources, but an abscess tooth is also a potential source for infection. Dental implant implications. Implant placement. Implant placement in surgical sites that have been previously affected with osteomyelitis leads to an increased morbidity. Because of lack of vascularity, endogenous implants have a greater chance of bone loss, infection, and failure. Radiation. Although the survival rate of patients with head and neck cancer has increased over the last 20 years, it still remains one of the deadliest forms of cancer. Aggressive treatment includes surgery, radiation, chemotherapy, or a combination therapy that inevitably leaves the patient with a compromised anatomy and physiologic functioning. Patients are left with many deficits, including oral mucositis, xerostomia, compromised healing, and reduced angiogenesis. Dental implant implications. Osteoradionecrosis. The most significant risk in placing implants into irradiated bone is osteoradionecrosis, which is an irreversible devitalization of irradiated bone characterized by necrotic, soft bone that fails to heal properly. The pathophysiologic mechanism is an imbalance in oxygen demand and oxygen availability, which is caused by endarteritis of the blood vessels. Smoking. In the United States, an estimated 42.1 million people, or 18.1% of all adults, smoke cigarettes. Overall smoking prevalence has declined from 2005 to 2012, from 20.9% to 18.1%. However, tobacco is still the most preventable cause of death and disease in United States. Dental implant implications. Increased incision opening. Studies have shown that smoking is directly related to increased incision line opening. Possible mechanisms for poor wound healing include vasoconstrictive nature of nicotine, increased levels of fibrinogen, HP, and blood viscosity, increased platelet aggregation, and impaired polymorphonuclear neutrophil leukocyte function. Therefore, additional sutures along with tension-free closure are recommended. Infection. Tobacco smoke decreases polymorphonuclear leukocyte activity, resulting in lower motility, a lower rate of chemotactic migration, and reduced phagocytic activity. These conditions contribute to a decreased resistance to inflammation and infection. Implant or bone grafting failure. Meta-analysis studies have shown a definite correlation between smoking and failure rates of implants and bone grafts. Peri-implantitis. Studies have shown in smokers a strong correlation between peri-implantitis and dental implants. Informed consent. With the possible detrimental effects of smoking on implants, it is recommended that patients be informed in detail about the risk of smoking. These possible consequences include increased marginal bone loss after implant placement and presence of peri-implantitis. Additionally, there is direct effect of the success rate of bone grafts, with almost double the failure rates in implant placed in grafted maxillary sinus. Smoking cessation. A strong recommendation on smoking cessation before and after implant surgery is recommended because it has been shown to decrease implant morbidity. Ideally, the patient is instructed to cease smoking for 2 weeks before surgery to allow for reversal of increased blood viscosity and platelet adhesion. Smoking cessation is continued for 8 weeks after implant surgery, which coincides with the osteoblastic phase of bone healing. It has been shown to increase the wound healing capabilities and reverse subgingival microflora. Treatment summary. Any amount of smoking is relative contraindication. Excessive smoking, that is greater than 1.5 packs per day, is absolute contraindication until smoking cessation. Bisphosphonate protocol and suggestions. Oral bisphosphonate used less than 3 years.
Proceed with the surgery with detailed oral and written informed consent for bisphosphonate-associated osteonecrosis and possible decreased implant healing. Decrease comorbidities, that is periodontal disease, infections, smoking, etc. Strict adherence to antibiotic prophylaxis and antimicrobial use. No prophylactic corticosteroids. Elective CTX test, that is C-terminal telopeptide test. Now use greater than 3 years. Proceed with surgery with detailed oral and written informed consent for bisphosphonate associated osteonecrosis and possible decreased implant healing. Decrease comorbidities, periodontal disease, infection, smoking, etc. Medical clearance and strict adherence to antibiotic prophylaxis and antimicrobial use. No prophylactic corticosteroids. And CTX test or drug holiday. Drug holiday by physician only, that is 9-month pre-surgical plus 3-month post-surgical. Now laboratory risk assessment. If the CTX value, which is given in picograms per milliliter, 300 to 600, there will be no risk of osteonecrosis. If it is 150 to 299, risk of osteonecrosis is none to minimal. If it is 101 to 149, risk of osteonecrosis is moderate. And if it is less than 100, there is high risk of osteonecrosis. IV bisphosphonate is absolute contraindication. Chapter 11. Radiographic evaluation in oral implantology. One of the keys to preventing potential complications during the surgical and prosthetic phases of implant treatment is to have a clear picture of patient's current anatomic makeup as possible. Identifying deficiencies of bone allows the clinician to modify the bony architecture to achieve optimal implant location for prosthetic success. Knowing the exact locations of vital structures allows us to plan safe zones during treatment to avoid potentially catastrophic complications. Proper planning is absolutely paramount to success in any endeavor, and having a strong plan in place before the initiation of implant treatment is no exception. Conbeam technology has ushered in a new era of accuracy in treatment planning. Clinicians are no longer having to rely on guesswork by extrapolating anatomic measurements from a distorted 2D image. Templates may be based on these new 3D images to assist clinicians during tough surgical cases, especially early on respective learning curves. There are just so many benefits to using CBT technology that it is hard to distinguish a reason not to possess one before the initiation of implant treatment. Present legal climate is beginning to echo this sentiment as CBT is closer to becoming the standard of care across the board. With a combination of 3D imaging and a thorough knowledge of anatomic areas, a clinician can acquire a further degree of confidence that the likelihood of complication has been reduced, which makes the implant treatment process less stressful for both patient and provider. Chapter 12. Applied Anatomy for Dental Implants. Surgical anatomy of maxilla and mandible provide the foundation required to safely insert dental implants. The anatomy is also a requisite to the understanding of complications that may inadvertently occur during surgery, such as injury to blood vessels or nerves, as well as post-operative complications such as infection. Surgical anatomy of maxilla as an organ. Maxilla is pyramidal in shape, the root of the zygoma as its apex. The latter can be palpated in the buccal vestibule of the oral cavity. Root of zygoma divides the facial surface of maxilla into anterolateral and posterolateral surface of the pyramid. The third surface of pyramid is the orbital plate of maxilla. Base of the pyramid is the lateral wall of the nose or the medial wall of the maxillary sinus. Alveolar process of maxilla related to the anterolateral surface carries incisors, the canines and the premolars, whereas that of posterolateral surface carries molars and ends as a maxillary tuberosity. The opening of maxillary sinus is found in the medial wall of maxilla close to the floor of orbit. The opening is reduced in diameter by uncinate process of ethmoid bone. The latter provides the superior and middle concave of lateral nasal wall. The orbital plate of maxilla forms the floor of the orbit and also the roof of maxillary sinus. The infraorbital canal carries the infraorbital nerve and vessels, and it forms a ridge that can be seen in the sinus cavity. Anatomic features of maxilla and mandible that are of clinical importance. Frontal process of maxilla, infraorbital foramen, anterior nasal spine, pterygomaxillary fissure, canine eminence, canine fossa, posterolateral surface of maxilla, coronoid process, retromolar triangle, external oblique ridge, mental eminence, mental foramen. Anatomic features of maxillary sinus are maxillary sinus opening, middle meatus, medial wall of sinus, lateral wall of sinus, floor of sinus, and alveolar recess. Muscles attached to the maxilla. As the maxillary alveolar bone resorbs, the crust of residual ridge migrates towards the muscles that take their origin from basal bone of maxilla. Orbicularis oris muscle. Orbicularis oris muscle originates from modiolus at each corner of mouth. The muscle fibers fan out into upper and lower lips, in which they form upper and lower peripheral portion under the skin and marginal portions under the vermilion zone of lips. Orbicularis oris receives innervation from buccal and mandibular branches of facial nerve. Incisivus labii superioris muscle. Incisivus labii superioris muscle originates from the floor of incisive fossa of the maxilla, above the eminence of lateral incisor and deep into orbicularis oris. To expose the bone of premaxilla between the canines, a mucoperiosteal flap reflection may detach the incisivus labii superioris. These small muscles will reattach after placement of the flap. However, if the muscles were damaged, then drooping of septum and flaring of ala of nose may result. Buccinator muscle. Buccinator muscle originates from base of alveolar process opposite to the first, second and third molar of both jaws. This muscle also takes origin from pterygoid hamulus of the medial pterygoid plate of sphenoid bone, bridging the gap between maxillary tuberosity anteriorly and the hamulus posteriorly. When incising and reflecting the mucosa overlying the area of maxillary tuberosity and hamular notch before taking impression for maxillary subperiosteal implants, avoid injuring the tendon of tensor villi transact muscle which passes around the pterygoid hamulus. Levator anguli oris muscle. The levator anguli oris muscle originates in the maxilla below the infraorbital foramen. The infraorbital nerve and vessels arise between this muscle and the levator labii superioris. In the severe atrophic division D maxilla, the infraorbital foramen is relatively close to the crest of the ridge. The reflection of the tissues for autogenous grafts and implant placement into the sinus grafts may approximate this region and cause paresthesia. In subperiosteal implant cases that require extensive framework extension for retention, the operator should be aware of the location of infraorbital neurovascular bundle in relation to the caninus and levator labii superioris muscles. Zygomatic branch of facial nerve innervates the caninus muscle. Sensory innervation of maxilla. Maxillary nerve innervates the maxilla. Posterior superior alveolar nerve. The nerve arises within the pterygopalatine fossa, courses downward and forward, passing through the pterygomaxillary fissure and enters the posterior aspect of maxilla. It runs between the bone and the lining of the maxillary sinus. This nerve supplies the sinus, the molars, buccal gingiva and the adjoining portions of the cheek. It may be injured during a sinus augmentation with a lateral approach.
Infraorbital nerve. This nerve is a continuation of the main trunk of maxillary division. It leaves the pterygopalatine fossa by passing through the inferior orbital fissure to enter the floor of the orbit. It runs in the infraorbital groove and then in the infraorbital canal. The nerve exits the orbit through the infraorbital foramen to give cutaneous branches to the lower eyelid, ala of the nose and the skin, and mucous membrane of the lip and cheek. When applying only grafts which expose the entire maxilla, the implant dentist must be aware of this situation. Fixation screws or implants may cause paresthesia when inserted through the graft into its structure. Subperiosteal implant designed for an atrophied maxilla should not extend into the site of infraorbital nerve and vessels. Middle superior alveolar nerve. This branch of infraorbital nerve is given off as the infraorbital nerve passes through the infraorbital groove. The middle superior alveolar nerve runs downward and forward in the lateral wall of sinus to supply the maxillary premolars. Anterior superior alveolar nerve. This branch of infraorbital nerve arises within the infraorbital canal. It initially runs laterally within the sinus wall and then curves medially to pass beneath the infraorbital foramen. The branch turns downward to supply maxillary anterior teeth. A nasal branch passes into the nasal cavity to supply the mucosal lining of a portion of nasal cavity. Posterior, middle and anterior superior alveolar nerves run in the facial wall of the maxillary sinus between its lining membrane and the bone. During antrostomy procedures, to augment the floor of sinus, the operator should be aware of these structures which are present even in the absence of teeth. The greater palatine artery and vein accompany the nerve during its course in the hard palate. As the maxillary alveolar process atrophies, it shifts to the palate and brings the crest of the ridge closer to the groove in which the greater palatine neurovascular bundle is found. Restoring the dentist should be aware that an incision too palatal to the crest of ridge in the atrophied maxilla might injure these vital structures. Nasopalatine nerve. The nasopalatine nerve leaves the pterygopalatine fossa through the sphenopalatine foramen located in the medial wall of fossa. The nerve supplies the nasal mucosa, descends to the floor of the nose near the septum, passes through the nasopalatine canal and then exits onto the hard palate through the incisive foramen. The latter opening is deep in the incisive papilla. The nerve communicates with the greater palatine nerve. The incisive nerve should be anesthetized before elevation of mucosa floor of nose for subnasal graft or implants that engage the nasal floor in the incisor region. Arterial supply to maxilla. The majority of arterial blood supply comes from the maxillary artery, which is one of the terminal branches of external carotid artery. Branches of maxillary artery are as follows: mandibular portion, pterygoid portion, pterygopalatine portion, and infraorbital portion. All arterial branches arise from the external carotid. Therefore, bilateral atherosclerosis of carotid, which is common in old age and in uncontrolled diabetic patients, may compromise the blood supply to the maxilla and could result in delay of healing after insertion of implants or bone grafting to the area. Arterial supply of maxilla and mandible are ophthalmic artery, infraorbital artery, deep temporal artery, posterior superior alveolar artery, middle superior alveolar artery, anterior superior alveolar artery, buccal artery, inferior alveolar artery, middle meningeal artery, maxillary artery, superior temporal artery, external carotid artery, mental branch of inferior alveolar artery, facial artery. Surgical anatomy of mandible. This symphysis, inferior border, premesenteric notch, gonial angle, lateral pole of condyle and coronoid process are all palpable under the skin. Intraoral palpable features of mandible from the facial surface include external oblique ridge and retromolar triangle with a coronoid process at its tip, the external oblique ridge bordering it laterally and internal oblique ridge bordering it medially. An atrophied edentulous mandible loosens the alveolar process, and the crust of the ridge may be found at the same level as external and internal oblique ridge. It is possible to palpate the superior genial tubercle with its genioglossus muscle attachment. Reflection of mucoperiosteal flap after the mid-crust incision may expose the mental neurovascular bundle, which is abnormally located at or occasionally lingual to the crust of the ridge. Transact muscle may loosen its attachment to the external oblique ridge, whereas the mylohyoid may rise above the level of the ridge. The lingual nerve, which has a close relationship to the alveolar bone of the third molar in the dentulous mandible, may run close to the crest of edentulous ridge. In some cases, it may be found under retromolar pad. Muscle attachment to the mandible. The loss of teeth begins a cascade of events that lead to alveolar bone loss in width and height. As the mandibular alveolar bone resorbs, the residual ridge migrates towards many of the muscles that originate or insert on the mandible. Genioglossus muscle. The genioglossus muscle forms the bulk of the tongue. During the elevation of lingual mucosa and before making an impression for a subperiosteal implant, one should be aware of the origin of this structure to avoid causing injury during the procedure. Medial pterygoid muscle. Surgical exposure of tissue posterior to the maxillary tuberosity may also involve the medial pterygoid muscle because a portion of muscle takes origin from the maxillary tuberosity. Lateral pterygoid muscle. Although the lateral pterygoid muscles rarely are involved in surgery for implants, their possible action in mandibular flexure and adduction during opening as well as the effect of this phenomenon on subperiosteal implants or prosthetic full-arch splinting of mandibular implants in the molar region warrants their consideration. Temporalis muscle. Incisions placed on the anterior ascending ramus for subperiosteal implants or harvesting bone from the external oblique and ramus should be inferior to the insertion of two tendons of the temporalis muscle. Buccal or facial muscle attachments. Mentalis muscle. Complete reflection of mentalis muscles for the purpose of extension of a subperiosteal implant or symphyseal intraoral graft may result in wet skin, probably caused by the failure of muscle reattachment. If the muscle is completely detached to expose the symphysis, then an elastic bandage is applied externally to the chin for 4 days to help in the reattachment of the muscle. Buccinator muscle. Some patients wearing lower subperiosteal implants complained of episodic swelling and pain at the site of origin of the transaction muscle, particularly after a period of heavy mastication or bruxism. Masseter muscle. The muscle can be deflected easily during surgery to expose the bone for the ramus extension needed for the lateral support of subperiosteal implant. The space between mesenteric fascia and muscle is a potential surgical space known as mesenteric space, into which an infection may spread causing myositis and trismus. Innervations of lower jaw and associated structures. Inferior alveolar nerve. This nerve arises as a branch of mandibular nerve in the infratemporal fossa. The inferior dental nerve can run as one unit through the mandibular canal until it reaches the premolar region, in which it divides into mental and incisive nerves. Knowledge of the position of inferior dental canal in vertical and buccolingual dimensions is of paramount importance during site preparation for implants. Lingual nerve. Lingual nerve is a branch of mandibular nerve that is given off in the infratemporal fossa. Improper reflection of the lingual mucoperiosteal flap may injure the lingual nerve and produce ipsilateral paresthesia or anesthesia of the innervated mucosa, loss of taste, reduction of salivary secretion. The extent of involvement depends on the degree of injury to the nerve. Nerve to mylohyoid. The mylohyoid motor branch of inferior dental nerve is given off just before the nerve enters the mandibular foramen. Because the nerve is so closely related to the ramus of the mandible, the surgical interventions in this area may lead to injury of this important motor nerve. Long buccal nerve. This nerve is a sensory branch of mandibular division of the trigeminal nerve and is distributed to the skin and mucous membrane of cheek and buccal transept opposite the mandibular molar region. The implantologist who is planning to assess the ramus for the purpose of excising block graft should be aware of the buccal nerve and avoid injuring it. In addition, surgical manipulation in this area, that is during insertion of a subperiosteal implant, may injure this nerve. Blood supply to the maxilla and mandible. The blood supply to both the mandible and maxilla is derived from a common source, the external carotid artery. The external carotid artery is the branch of common carotid artery, which is a direct branch of arch of aorta on the left side and a branch of brachiocephalic artery on the right side of the body. The main artery supplying the mandible is the inferior alveolar artery. It serves as a nutrient artery to the bone and other tissues within the lower jaw. The bone tissue of maxilla is supplied by branches of two major vessels, the posterior superior alveolar artery and the infraorbital artery. The major branch of infraorbital artery that supplies the maxilla is the anterior superior alveolar artery. Posterior superior alveolar and infraorbital arteries are branches of maxillary artery, which is one of the two terminal branches of external carotid artery. The mandible and maxilla are membrane bones and as such do not develop in same manner as long bones. Most researchers agree that the circulation of blood within the body of mandible and in the maxilla is centrifugal under normal conditions. As in the long bones, endosteal and periosteal plexus exit that are connected with one another. In addition to these vascular networks, a periodontal plexus is found associated with the teeth. When teeth are present, intraosseous vessels send branches into alveolar processes, to the teeth and to the branches of periodontal plexus. The intraalveolar arteries and periodontal plexus in turn connect with the vessels of periodontal plexus as well as with the vessels within the soft tissue surrounding the bone. Once a tooth is removed, its periodontal plexus is lost. When abnormally circulatory condition exists within the mandible or maxilla, such as occlusion of nutrient artery, the blood supply to the bone is reversed so that the direction of flow is from the outside to the inside of the bone. This is called centripetal circulation. Maxilla. The vessels that supply the maxilla are branches of the third part of maxillary artery. In surgical procedures, the major nutrient arteries to the maxilla are sometimes severed, but the blood supply is maintained by means of anastomosis present in the soft palate. The vessels of the soft palate unite with the vessels of hard palate, which in turn communicate with the periosteal, periodontal and endosteal plexus of the upper jaw. Thus, the vitality of tissues of maxilla is maintained through an arterial supply derived entirely from the vessels that normally supply the soft palate. Mandible. The changes in pattern of blood flow to the atrophic mandible are of special importance to implant dentistry. Mucoperiosteal flap reflection for subperiosteal implant usually exposes 75% of body of the mandible and approximately 50% of inferior one-third of the rami. Presence of the mucosa at the incision lines has been reported. The reduction in atrophied bone blood supply may be a contributing factor. Onlay grafts from the iliac crest to severely atrophied mandibles are also associated with occasional incision line opening post-operatively. Limitations of surgical reflection of muscles that attach to the bone improves the blood supply but may complicate primary closure without tension. However, muscle attachment at basal bone of mandible, which are not in the way of graft placement, should not be reflected. In addition, endosteal implants placed in an atrophied anterior mandible may have less blood supply to the interface and may require longer time for load-bearing bone to develop. Misch has suggested 5 months of healing in very dense bone when found in an atrophied anterior mandible. Implantologists may encounter neurovascular bundles such as infraorbital, incisal, greater palatine, anterior, middle and posterior superior alveolar nerves in the maxilla during antral augmentation procedures or mucoperiosteal flap reflection, and the mental nerve, inferior dental nerve and lingual nerve in the mandible during placement of root or blade implants or reflection of microperiosteal flaps. Stretching, compression, partial resection or total transaction can mechanically injure the nerve. Nerve fibers of peripheral nervous system show greater capacity for regeneration than nerves of the central nervous system. The Schwann cells and the basal lamina are indispensable for axonal regeneration because they retain growth factors. Schwann cells also provide new myelin for regenerating fibers, although the conduction property is less efficient and the functional recovery may never be complete. The sprouting stage may cause pain to the patient and the area may be sensitive to touch. The rate of recovery will depend on type of injury. Thank you.